About myself, I am currently in Chicago serving as a leukemia coordinator. This may not be reflected on my CV because I joined this 3 months ago. My journey starts in Pakistan. Both me and my twin sister, ever since we were young, we really looked up to our dad, who was a great physician in our eyes. And the way his job seeped into his personal life, how he would come home, not drained, but revitalized of how his job kindled his passion. I think both of us saw that love and we also wanted to follow it. And that did lead us both to med school, in fact. Once I was in med school, I was so sure that I made the correct decision. I was rounding with such spectacular physicians. And at that point, I realized I had chosen the right career for myself. I was also taking part in extracurricular activities, like I was part of our soccer team. I was the president of our music society. I have an avid love for music, love to sing. And once I graduated, COVID-19 dawned upon us. And at that point, on those crossroads, I decided to take a flight to Louisville, and that started my healthcare journey in the US. I've been here 3 years ever since. I have rotated at three different institutions, namely where I was in infectious diseases, at where I was in the ophthalmology clinical trial office, and thirdly, where I currently am is apart from that, when I'm not wearing scrubs, I love to explore different coffee shops with my wife. We love playing ping pong, and I often lose, but in return, I subject her to my cooking and the experimental dishes I make.
Wonderful. Now it sounds like you've been all over the place. A lot of the time in Chicago, which is a big city. How are you going to transition from a big city to a small city? Like, remember, this is not New York City. Some people get it
Mhm.
confused. What do you think about that transition?
Both me and Fatma are accustomed to a more remote lifestyle. I was in Kentucky, I was in Louisville. Fatma has her family in Rhode Island. In fact, very recently, I was in Rhode Island this past week and I absolutely love the place. And both me and Fatma are really looking forward to a lifestyle that's far from the city life because sometimes the city life does get burdensome. I think that's an absolutely gorgeous state. We have so much family there, and I would love to be settled there with Fatima.
What led you to not go into a residency specialty right away or residency right away?
Great question. And that was a difficult decision for me because you see all your peers going to residency programs. But at that point, two factors came into play. One, at that very moment in life, the whole world came to a standstill and COVID-19. And I had a wonderful opportunity in front of me at Division of Infectious Diseases to train with Dr. Louis Marsano, who's been a pioneer in infectious diseases. And that's where I really thought that this was the perfect opportunity for me to actually learn evidence-based learning, not only through manuscript writing, but write on the field with patients in clinical research. So at that point, I thought, what better way to actually learn about the best healthcare system in the world? And that led me to getting enrolled in HIV trials, meningococcal carriage clinical trials, COVID-19 clinical trials were happening at that point. And I felt very content that I was learning from the best, being in the best healthcare system possible. Second factor that came into play was the fact that I desire to pursue a competitive fellowship like hematology down the road. During residency, I want to solely give my time to absorbing as much clinical knowledge as possible, refining my bedside manners, learning how to properly function as an internist. So before residency, I allowed myself to take part in research, learn it properly, and I'm so sure that it will serve me one way or the other down the road. And this knowledge will be imparted to other med students as well down the road.
Hmm. You talked about medical students. How are you going to specifically support them in the clinical setting?
I think I've, in the past 2, 3 years, I have particularly emphasized upon the teaching aspect of medicine. I love teaching, and I've always been a part of mentoring researchers when they were onboarding, when questions were thrown at my way. It also made me realize how much gaps were present in my own knowledge as well. It's called the teach back method. Incorporating all of this with medical students, I realized this is something that I want to continue down the road as well. Once I am hopefully at medical center as a resident, down the road as a fellow, I would love to work in a team. I would love to train new medical students, researchers, and it's mutual growth for all of us.
So I had a patient this morning where he was just diagnosed with lung cancer, specifically small cell lung cancer. And we had to tell him that he has 6 months to live. And he was very set on just being done, not having any treatment. However, his wife really wanted him to try to extend his life and to try the chemo. How would you balance this situation?
That's a great question and a scenario that we always should expect to come across. I think that really calls in the elements of informed decision making. And informed decision making does require a patient to be fully informed. And as it falls on us, the duty as residents, as doctors, is to make sure that the person's comprehension level fully grasps the pros and cons of the decision he's making. He knows what his rights are and what his rights to refuse treatment as far as that goes. Hematology and oncology particularly face this slight subtle aspect where patients are also greatly stigmatized as to what is coming towards them when it comes to chemotherapy, radiotherapy, and that particular stigma can be tackled if you really make sure an empathic approach is made to make sure the patient is understanding what's going on. That is, in fact, a really great question. And if I was to tackle such a situation, I would love to call in a social worker. I would love to call in a different team member who's more learned on this matter to make sure that the patient has been fully informed. And once they're fully informed, we do have to respect their decision. And if a patient declines, unfortunately, the wife's discretion will not be entertained because the patient, if he is fully cognizant, if he's fully comprehending, we do have to respect that as a part of patient's autonomy.
Now, you said that you came over during the COVID type period. What did you learn about how the health system works in regards to vaccination hesitancy and how to mitigate when people are dying?
How to mitigate? Could you repeat the
Like,
latter?
yeah, no, that was a bad question. More, what were the things that you learned in the infectious disease standpoint of working with patients that are vaccine hesitant, having a population that is very much in need of vaccinations and the population as a whole?
That's
So, like,
that
what did you
is
learn
yeah.
about how that worked, COVID?
And that's a great question, in fact. And I've had a conversation with one of the other attendings at the hospital when I was transferring over. And that's the problem. That's a very real problem on the field. You see this. And there's one thing seeing these things in theory and then seeing in the practical world. And southern US did have lots of hesitancy when it came to vaccinations, and it did create problems. I also felt that there was this prevalent problem, and lots of it stemmed from misconceptions through media. Lots of it stemmed through misconceptions about what the vaccine actually entailed. Many people didn't believe it to be efficacious as possible. Our job as then researchers was to inform them, bring about health awareness, and actually bring the conversation to a medical side of things rather than a social aspect that's prevalent on media. I think that element of population-based health needs to be incorporated into our clinical care. I think that's one of the very key elements I learned in clinical research. They go hand in hand. And I feel down the road, both of these working together at a hospital which faces struggles financially against the underserved population with such policies incorporated, and it's doing a great job, and it will definitely serve it down the road as well.
You mentioned the underserved population that we have. How do you hope to give back to this community?
Yeah, I come from a very humble background, and seeing myself sitting here across you, a program director from such a renowned institution, it's definitely a dream come true. But we don't forget our humble beginnings. I come from 7,000 miles away, and I've seen people suffer from healthcare disparities, socioeconomic imbalances. Most people don't even know what their rights are, what their rights to healthcare are, what the options are available. And I believe when we are privileged so much, it's our duty, it's our obligation to serve, to make sure that we are there to lend them a helping hand. Has done an incredible job, and I do believe I would love to be part of such a community which has the star pointing towards helping people. Every other month, we used to visit homeless shelters, set up medical camps, take vitals, physical assessments, and most importantly, inform them, particularly about HIV treatments available, because that was an epidemic that literally inculcated empathy in me and my team, and we realized that medicine is so much more than dealing with just a diagnosis.
Something that means a lot to us in this institution is being ethical. And so, how would you handle a situation where you notice that one particular co resident is not actually seeing his patients and they are just only doing the EMR work? They're never actually doing a physical exam or even seeing the patient. How would you handle this situation?
That's a crucial situation to be dealt with. Ethics lays the groundwork of us as physicians. I think that's a core value that cannot be compromised on. We are dealing with patients' lives. It needs to be taken seriously. And if a resident, if a fellow, if a co-worker is in such a situation, it is a moral obligation on my part to one, address the situation calmly, openly in a separate setting and ask them if there's anything I could help with, if there's some question of comprehension playing a part, if they're uncomfortable with dealing with certain diagnoses or comorbidities. If that's not the case, and if it falls out of my level of expertise, I would definitely want to get a coworker involved, and so they could talk to them in a discreet setting, talk to them openly, and address what's happening. Because for us, first and foremost, what our priority should be patient safety, enabling patient safety, and making sure the concept of non-maleficence is in play, the concept of patient autonomy and beneficence is in play, and those elements have to be our.
Now, you mentioned all these fancy academic institutions that you've worked with. What will be the difference between those institutions and our community hospital?
That's a very different question. I think I have always gauged an institution as to what I could bring to it and what they could bring to us. Every institution out there is making monumental changes. No matter the patient population they're seeing, I have equal respect for all institutions all around the world. I think it's all about transferable skills, and I have gained a certain set of skills working at each and every institution. I carry some emotional and some intellectual lessons for each and every encounter, co-worker, senior, or patient. Working in an institution which really aligns with my core values, the lessons I've learned, the knowledge that I bring with me, it's finally my time to implement them, work on it, and be actually a contributing part to this healthcare community. I have long dreamt of being on the field and working one-on-one with patients, and I feel working in these institutions will undoubtedly serve me and the people I'm serving, and the journey continues.
Well, obviously, we don't have a lot of research, but we are still an institution that wants to improve our research opportunities. How are you specifically going to help us with this mission to improve our research?
Yeah, I think that's a great question because I do take pride in the fact that I have this deep in my heart, a wonderful liking of research. Doctors at the Cancer Center are pioneers in hematology and oncology, and their clinical trials that are starting, even research at the IRB here. I think one way or the other, if I can contribute in any way, I would love to. There are quality improvement projects that can take place, there are scholarly activities taking place that I would be happy to serve in any capacity possible, even if it's not a clinical trial, even if it's just simply explaining or learning along with my team members what IRB is, what a protocol is, how to follow it. I think clinical research is so much more than manuscript writing. It's more about studying the ethics of teaching others about a protocol, studying how your decisions can influence populations rather than a single person. And all of these elements, I do believe, have a wonderful outlet in the form of the Cancer Center present here. And that actually does prompt a question in my mind too. How much residents would be involved with the Cancer Center if they can be? Because I think that's a question that's been hovering on my mind. I would love to be someone who's engaged in work with the question.
Yes, very good question. And it got me actually thinking of something that's really important to us is we want individuals after their 3-year residency to stay here or at least come back in some capacity. So what does this city bring or the community interest you or what would bring you back?
I was there last weekend, and I can tell you I absolutely fell in love with the state. It's beautiful. The campus is amazing. Rhode Island is sprinkled with family for me. And Fatma and I are at the stage of life where we would just want to settle in one place and really follow our passionate careers. And I do feel on a professional side of things, I see myself down the road, if I'm fortunate enough, if I'm lucky enough to gain a competitive fellowship there in hematology and oncology, and they're two in-state fellowships, so there are options for me. And if I'm lucky enough, I see myself as a teaching faculty member who's working in a hospital there, who's giving back to the community, leading a quiet life and working alongside great physicians like you yourself, such an amazing faculty. And I think that's what a student like me at this stage can just only dream for. And I would love for that dream to come true.
Now, as we start to finish up, are there any questions you have for me?
Yeah, so many questions, but due to the time constraint, I'll stick to only two. First of all, thank you so much for interviewing me. It's been a pleasure. I thoroughly enjoyed this as a conversation, and I hope I didn't bore you too much. Question one for me would be, how has your experience been? Because you as the program director has the most unique outlook to this program, viewing it from an angle which no other can view it from. And second question I have is a more structural question. Is I do have a vision in mind when I look at, and I see a vision that follows for a couple of years, in fact. How do you see this program changing? And what core values should the resident bring in? And what core values is bringing in that could, in your eyes, really thrive in a relationship between them? Long story short, what core values do you think a resident should keep in mind when they're going through their residency in this program?
Very good. Next interview you have is with Dr.